Okay, so I'm going to start with the introductions. It's going to be very short and brief because I don't want to take away from the discussion that we're going to hear today. So the guest speaker is Dr. Judith Wiley-Rosette, professor and division head of health promotion and nutrition research in the Department of Epidemiology and Population Health from Albert Einstein School of Medicine. I would like to tell you that her contributions to the study of nutrition is numerous, and while she is not here neither as an officer or representative of the American Diabetes Association, she has participated in the framing guidelines of that association and other agencies. So I just wanted to give you that little disclaimer. The format of today's discussion will be a 15-minute presentation, first by Dr. Richard Feinman, followed by a 10-minute rebuttal by Dr. Wiley-Rosette. Then Dr. Wiley-Rosette will give her 15-minute presentation, and then they'll each take turns rebutting each other's positions. So this promises to be a lively debate only because of the opposing viewpoints of the guest speakers, but both parties have assured me that the intensity will not come close to what we see in the presidential Republican debates that we've been seeing. And I too promise that I won't ask questions about their investments in Freddie Mac and Solyndra and all that kind of stuff. After that, rebuttals, then we'll open the floor to you guys for questions and answers. We benefit because I tell them I know nothing about the issues, and now we're going to see what the therapeutic protocols may be for people afflicted with diabetes. With that, Dr. Richard Feinman.
Okay, thanks. I'm grateful to Dr. Wiley-Rosette for taking part in this discussion. The debate on macronutrients basically follows from the GI block, and most of you will recall that we came to the conclusion that the science was pointing to dietary carbohydrate restriction as the default treatment for diabetes and metabolic syndrome, that is, the one to try first. And Dr. Wiley-Rosette, when I raised this question, she sent me this very recent discussion, a systematic review of macronutrients, and I think this is a good place to start. Let me say before I begin that I'm highly critical of this document and other things, but I'm not critical of Dr. Wiley-Rosette, just the opposite. I think this kind of discussion will help us a lot. Now, the systematic review sets out a protocol for searching the literature and is along the lines of what's known as evidence-based medicine. And in considering that, I've made the point that we might consider evidence-based medicine by analogy with the legal system, which is the other area in which we are concerned with evidence. And in court, a judge decides on the admissibility of evidence. You don't get to say, this is the evidence. The judge has to make a decision. And my criticism of this systematic review will be that where it's systematic in searching the literature, it's, again by analogy, lacking in motive. And the point is that science is a bottom-up discipline. In other words, we don't look at every chemical in the world at random. We have a basic theory of chemical reactivity, and underlying that we have physics. We know something about diabetes. It's a disease or several diseases of carbohydrate intolerance. Now, we also know the broad outlines of the biochemistry of glucose-insulin axis, which you've all been through. I'll do this very quickly. What we know about diabetes, of course, is greatly outweighed by what we don't know, but we have some basic ideas, and that is that glucose is the major stimulus for secretion of insulin by the pancreas, and that insulin is generally anabolic, increases the uptake of glucose, and most important, inhibits hepatic production. In other words, insulin turns off your own ability to make glucose in the presence of glucose. Equally important, or maybe more important, is that it inhibits lipolysis. That is, it is anabolic in terms of the storage of fat. Now, in diabetes, or the related insulin resistance, what happens is that there's a failure to inhibit hepatic production. There's also a decrease in the ability of peripheral cells to take up glucose. There's disinhibition of fatty acid breakdown, so there's an increased fatty acid, which in turn may cause further insulin resistance. The bottom line is that the most salient feature of both type 1 and type 2 diabetes is hyperglycemia, and often a compensatory hyperinsulinemia. It's reasonable to say that if you have hyperglycemia, you don't want to add any more dietary carbohydrate. And our point of view here is that this is a basic idea, and that the burden of proof is on people who say that this is not right. Of course, there are many confounding issues in medicine, so you do have to show that the basic principle is consistent with what you find. And I'll start with the last slide, because this is one of the most telling experiments. It's from the laboratory of Nuttall and Gannon at the University of Minnesota. And they're very careful workers, and they have 8 men on a low carbohydrate diet. They have their own controls, and this is the result of 20% carbohydrate. The important things about this are, first, that you get a fairly dramatic reduction in blood glucose. These are the meals, breakfast, and the snack, and that's lunch. One of the important features, however, is that this experiment is designed so that the patient does not gain or lose weight. And the significance of that is that mechanistically, there's a lot of emphasis on the idea that weight loss or gain controls diabetes, and that's not a necessary feature. In addition, practically speaking, it's hard to lose weight. And this is good results without weight loss. The other feature is that this is what they call bioavailable glucose. It's not refined carbohydrates, it's not fructose, it's not high fructose corn syrup. It's what you eat that produces glucose. The cumulative effect of high blood glucose, which you see in hemoglobin A1C, is similarly reduced. Well, this is a small study, but there's nothing in it that suggests it shouldn't persist as long as people stay on this regimen. But let's look at the largest study we can look at, and that's the population study. And what you're looking at here is what happened in the epidemic of obesity and diabetes. Well, obviously we ate more, and what you're looking at here is the actual calories. This is the absolute amount of calorie intake. These are the years, 1971 to 74, as measured by this NHANES survey, it's Health and Nutrition Examination Survey. These are the percentages of macronutrients, and you can see that before the obesity epidemic we were at 42%, men are now at 49%. In any case, while calories increased, they didn't increase across the board. The increase in calories is due almost entirely to an increase in carbohydrate. If anything, fat went down. The absolute amount of fat for men and for ancestry fat decreased. Now, it's common to say that association does not prove causality, and that's only partly true, because if you choose to look at an association, you're testing a hypothesis. In other words, as Einstein put it, what you measure is determined by your theory. So this answers the question, do macronutrients control the downstream output of diet? And you can see that this does correlate with the increase in diabetes. However much this is not absolute evidence, I would make the point that a lack of an association is very strong evidence for a lack of causality. So the major barrier to actually increasing, to decreasing intuitively the amount of carbohydrate in the diet is the concern about fat. And you can see that fat, if anything, went down. This is a study from Duke, and the part, this further shows that on a low carbohydrate diet, the hemoglobin A1C went down. What's significant about this is that of the 21 patients, 7 came off their medication. Of the others, there were only 2 who were on medication who did not reduce the medication. And I would consider this very strong evidence for the efficacy of dietary carbohydrate restriction. So what you get from carbohydrate restriction is improved weight loss, glycemic and insulinemic control, lower hemoglobin A1C, and a reduction in medication. And it follows from the basic idea that carbohydrate and fat are different. Carbohydrate is not just a fuel, but it's a control element. So this is the best analogy I could come up with. And the handle on the faucet determines whether dietary fat flows into storage fat or the generation of atherogenic lipoproteins. This is a widely quoted statement attributed to me, and it says the effect of saturated fat in the presence of high carbohydrate is different than the effect at low carbohydrate. And there's every chance that I actually said that, but it's certainly reasonable. And the main point is that if somebody does an experiment in which they say they're putting people on a high-fat diet by feeding them Big Macs, that's not the whole story. So let me describe a couple of other experiments. Remember that the glycemic index is a measure of the extent to which carbohydrate in the diet actually shows up as blood glucose. So this is a comparison of a low glycemic index diet with a high cereal fiber diet of the type recommended by the USDA. Now this was published in JAMA, and just by coincidence, the same day, the group at Duke compared a low glycemic index diet with a true very low carbohydrate ketogenic diet. And the results, I think, are pretty telling. The low carbohydrate diet, the true low carbohydrate diet, did better for weight loss, as we generally know, and glucose control, but showed a dramatic decrease in triglycerides, an increase in HDL, and not much difference in total cholesterol, which in any case is no longer considered a major predictor of cardiovascular disease. It is worth saying that all of these work. You know, all of these diets were helpful, but the argument that the low carbohydrate diet should be the default diet is shown by this data. So what is the risk if it's not dietary fat? We know that people with diabetes are at increased risk for cardiovascular disease. Well, this is the UK prevention study, and just focus on the most telling data, which is the correlation between amputation or death from peripheral vascular disease. This is microvascular complications, and the controlling variable is hemoglobin A1C. So what is it that puts people at with diabetes at increased risk for cardiovascular disease, it's having diabetes. It's the effect of glucose and insulin on the both glycation of proteins, which you've studied, and the metabolic drift towards a more atherogenic metabolic state. So, in addition, you get improved atherogenic dyslipidemia. That means triacylglycerol goes down, HDL goes up, and the small dense LDL, the arrow's going the wrong way. This should go down with improvement. And again, weight loss is not required. And nothing in these studies suggests that you won't get benefit as long as diet is followed. We don't need a random controlled trial. Nothing wrong with one. But the working hypothesis is that this will work. This will work in the long term because it works in the short term, and we don't have a long-term trial that does work well. Let me digress by saying that in all of these diet studies, there is the underlying assumption that we have a good diet that will protect against diabetes and cardiovascular disease, and that it's been tested. And there is no such diet. Okay, this is what is known in computers as vaporware. We just, it's not there. Every low-carb diets do better than other diets for as long as they're tested, and low-fat diets do very poorly. So what's the barrier? Well, there shouldn't be any barrier. The American Diabetes Association says that for weight loss, either a low-carbohydrate diet or a low-fat, if you can see the highlight, a low-fat calorie-restricted diet may be effective in the short term up to 1 year. This follows from the original study of low-carb diets that claimed that although they were better at 6 months, the diets were about the same at 1 year. Well, that's not quite right. The weight loss may have been the same statistically, but they were different numerically. More important, triacylglycerol, in this case the blue is the low-carb diet, triacylglycerol went down again dramatically, and the good cholesterol went up. So they're not really the same. But of more concern is the American Diabetes Association says for patients on a low-carb diet, monitor lipid profile. Well, shouldn't you monitor lipid profile for everybody? Well, when I asked Dr. Sue Kirkman from the ADA, she said, yes, that's true. She gave me permission to quote her on this. What is this really saying? It's saying, sure, go on a low-carb diet if you don't mind heart disease. In other words, this is a statement to get people not to try a low-carb diet. Did I exaggerate that? Okay, back to Nuttall and Gannon. So this is near the end of my talk, and it does show all the features that I said. You get good control. They've done 10 or 15 different studies at different levels of carbohydrate. They get the best results with 20% carbohydrate. Now, in the way of evidence-based medicine, this study, in fact, most of the studies, almost all of the studies of Nuttall and Gannon were not in the macronutrient systematic review that we showed at the beginning. Remember, hemoglobin A1C goes down also. There was 110 references. If you go through, the only one to Nuttall and Gannon was an earlier one from 2003. Now that one compared 55% and 40% carbohydrate rather than 20% and 55%. Well, of course, you don't get as big an effect. So this is evidence. This is evidence that what is characterized as a low-carb diet is not that great. This is this has the problem with evidence-based medicine. Nobody decided on its admissibility, and most of all, again, by analogy with a court of law, there's no cross-examination. I hate to think what Sam Waterston would do with somebody who tried to bring that into court. Okay, I'll skip over this. This is just the statement from Eric Westman saying that he's been able to taper patients off as much as 150 units of insulin per day in 8 days. That's a lot of insulin. I'll go through this quickly. This is not a study in diabetes, but is a diet study. And my only point here is that I'm not really, I don't think diets are the thing to look at. What we need to do is go back to basic biochemistry. And these diets show, in this case, that the mean weight loss was better on the Atkins diet than the others, but the mean doesn't tell you everything, and this is not, in my view, knockout results. But there are more telling parameters in the metabolic states. Now, each of these time points had the level of carbohydrate that was being consumed and the level of triglycerides. And if you now plot that data, you can see what's the controlling variable in this metabolic state. This is, for a nutritional experiment, this is pretty remarkable correlation. So let me tell you about the people's voice, because this is really important. This was an article in Diabetes Health by a registered dietitian who is bringing us a new reality. And the new reality is that Americans with diabetes should conform to 45 to 65% of calories. And they attribute this to the ideas of the American Diabetes Association and other health agencies. And in other words, people with diabetes should consume more carbohydrates than we're consuming now. They got a lot of responses. Respectfully, this column is not helpful to diabetics and probably dangerous. They've been doing 6 years of low carbs. Low carb and exercise has helped me control my blood glucose numbers. I have to agree with the comments, carbohydrates are very dangerous. The more carbs I eat, the more insulin I need. I actually feel very, very angry when I read advice such as Hope Warshaw. Quite honestly, I'm ashamed to call myself an RD. It flies in the face of logic. So the question is, are all these people lying? Do they not know what they're doing? There were 69 responses. Only one of them was negative. And that person said that the reason all the other responses were negative is because the low-carb people had gotten together to knock the article. As the president of the Nutrition and Metabolism Society, I can tell you, you can't get low-carb people together to do anything. This is a rebuttal to the American Diabetes Association guidelines, which were published in Diabetes Care. And I am grateful to Dr. Wiley-Rosette for trying to help me get this into Diabetes Care. However, they just blew us off. This has 24 authors. A couple of them are the directors of major endocrinology centers. And you know this is a good paper because 3 of the authors were at that time first-year medical students at Downstate Medical Center. I don't think they should blow us off like that. So what do we need? Well, first thing we need is more of what we got here. We need a public hearing, and we would do better if we got somebody relatively neutral like Congress or Health and Human Services, and everybody should be in the room, and in particular me and Dr. Wiley-Rosette. But we have to fund a long-term comparative study in which everybody participates, in which we sit down together and we, quote, write the paper first. We leave room for the data. We agree on what possible outcome we could get and what conclusions could be drawn. No Monday morning quarterbacking, no disclaimers. We ask the question and we answer it. Finally, we might need a new oversight organization, possibly one to decide on the admissibility of evidence-based medicine. We don't need a new bureaucracy. The National Science Foundation or the Office of Science and Technology Policy might be able to create such a thing. And we need people with no personal stake in nutrition. Nutrition is neither so technically complicated nor so profound that scientists could not be brought up to speed on that. And I'm sure Dr. Wiley-Rosette agrees with these goals, but may have something to add. Okay, that's it. Thank you.
I'm going to start in Brooklyn. And I have taken more of an agricultural policy kind of perspective, but not in this, but when we get to the discussion, I'd like to move it back to looking at some agricultural policy. But this is actually from the Department of Health. And what we have in Brooklyn is a high degree of advertising of alcoholic beverages, number one, juice drinks, energy drinks. So some of this increase in carbohydrate that Dr. Feinman talked about has been sugary beverage consumption. And that I see as one of the biggest challenges, but I think it goes back to some agricultural policy that we're reducing a lot of corn. We got to figure out something to do with the corn. So I think that I like to put that as beginning perspective. And this is a quote in terms of evidence-based medicine. There's several components of evidence-based medicine. One, oh, actually, I'm sorry, I'm not speaking to the microphone. One is basically evaluating the evidence, but I think the second part of it is having a shared decision-making with the patient, so that as we look at that shared decision-making, it's looking at some of the evidence. There certainly is some evidence about what the effects of carbohydrate are. There are people who are advocates for a vegan diet or a vegetarian diet who also quote evidence. But I think going through that evidence with a patient, if you, as a physician, will be the kind of thing in terms of looking at it. And looking at carbohydrate, looking at their own blood glucose testing, it can be a very useful way. But again, this is the official criteria for evidence-based medicine. And Dr. Feinman talked a little bit about a court of law. And in a court of law, there are two opposing sides in which they basically have already reached their conclusion and are trying to persuade other people to that conclusion. In medicine, the peer-reviewed journal process is supposed to do that, and there are some challenges with that. But I think that that is the method that has been used. And now there is a clinicaltrials.gov posting of all clinical trials, and then the clinical trials are evaluated by, against that, and they have to, so you can go to the website to see what they said they were going to do versus what they actually have done, because this actually has been much more of a challenge in terms of drug trials when they may have changed the design of the trial midway. This is basically how the American Diabetes Association did the review that Dr. Feinman talked to you about. And the search terms he had already shown you, and the criteria they used were clinical trials, prospective observational studies, cross-sectional studies, and case control studies, and meta-analysis. They had to have at least 10 participants per condition. So the reason the second Gannon paper wasn't in is because there were 8 people instead of 10. So these were preset conditions. 80% retention was considered desirable, and if the retention was less than 80%, they could be included in the review, but in the table it was noted that they had less than 80%. And they had to have the diagnosis of diabetes for all the subjects, or at least a subset with separate analysis. And the publication dates were from 2001 through 2010. And the confounders are basically medication, weight loss, and part of the recommendations are physical activity, and physical activity is a potential confounder as well. And I'm going to start with a meta-analysis that involved 13 studies. This was published in the Journal of the American Diabetes Association in 2008. involved 13 studies, and this is the definition of their low carbohydrate arm. It varied from basically very low carbohydrate, 20 to 22 grams of carbohydrate, and this actually is, I'm sorry, this is actually, I think there's a slide before this. I'm sorry, this is the randomized trial. The meta-analysis of randomized trials, and they looked at 13 trials, and they ranged, low carbohydrate arm ranged from 4 to 45%, but then they separated out the very low carbohydrate from the ones that are more moderate carbohydrate. And basically, I think that there was agreement that the A1C was lower, fasting glucose was lower, triglycerides were lower, the weight differences were more variable, and the cholesterol differences were more variable in this particular meta-analysis where they pooled all the data together. Unfortunately, in looking at the very low carbohydrate versus the moderately low carbohydrate, they had difficulty having enough. Some of the studies didn't report some of the sub-analysis, so it prevented that. But I think that there is agreement that we do see an improvement in A1C with lowering carbohydrate, particularly the postprandial glucose. But then I'm going to show you in a minute some studies that look at low fat, and I think the question is, is there more than one way to approach achieving glycemic control? You saw earlier the Westman study, and this is a comparison of the Westman study to a study published by Davis, and they both started with the comparison low carbohydrate diet based on the Atkins diet. One used Westman used a low glycemic index diet. The study that Davis reported used the low-fat diet that was used in the diabetes prevention program. Both gave recommendations of physical activity, but that was not a major part of the intervention in either one. The Davis one had enrolled 105 participants, 85 completed. The Westman enrolled 97, 50% completed the study. A randomized 97. They say they randomized about the same number. They approached the education a bit differently. The diet was designed isocalorically and using menus to start the approach in the one by Davis, reported by Davis, and both had algorithms for medication reduction, whereas the materials were used, counseling was provided, but the specifics in terms of calorie adjustment was not directly addressed in the Westman paper. Again, an intention to treat analysis versus limited to completer. So this would be considered an effectiveness analysis. This would be considered an efficacy analysis. Follow-up 1 year, 24 months. 24 weeks. And in terms of changes, you already saw the Westman changes, which were quite dramatic. They were on an efficacy analysis, they were less dramatic. Both groups at the end of 1 year saw improvements with not significant difference. In looking at the dietary intake, unfortunately in the Westman study, it was down to 15 people, 8 in one arm and 7 in the other. Calories were lower in the low glycemic index than in the low carbohydrate, but it was, again, a small subset of folks. The calories were lower in the low carbohydrate, and this came out to about 135 grams of carbohydrate compared to 49 grams of carbohydrate in the group at 24 weeks. So the diets were different. The populations were quite different. The Davis one was done in the Bronx, and 75% of the participants were minority participants, and the Westman study was done it was done at Duke, and it was more of it was, I think, about 30% African American, and there was a higher dropout rate of the African Americans in the low carbohydrate arms. So that these are some of the things in terms of trying to translate to practice that are challenges. This is a study that was published in the New England Journal comparing a low-fat diet, a Mediterranean diet, and a low-carbohydrate diet. And the low-fat diet, they were all designed, first two were designed with 1,500 calories, one with 30% carb, 10% calories from saturated fat, and 300 milligrams plus, which is pretty standard kind of recommendation. And the Mediterranean diet was 35% of calories from fat, and a heavy emphasis on using monounsaturated fat and nuts. And the low carbohydrate diet started with the 20 grams of carbohydrate and could go up to a maximum of 120 a day based on the Atkins diet. And these are the results. And you can see that initially the low carbohydrate did much better. At the end of a year, there was no significant difference between the Mediterranean and the low carbohydrate diet. The low fat diet did not do as well over the 24 months of follow-up in this study. This gives you the results in terms of the blood glucose and looking at C-reactive protein. Again, it was the best improvement was on the low carbohydrate diet. We see in terms of adiponectin, no different. The adiponectin level, no difference between two of the diets, whereas the low carbohydrate diet, there was a greater increase. Leptins were basically no significant difference in the three. Interestingly, in fasting glucose, in the non-diabetic group, there was no difference. The diabetic group, basically, the Mediterranean diet tended to do best. The low carbohydrate did well initially, then went back up. Part of this, one would have to look at the medication and medication changes. All three had a decrease in I'm sorry, this is the insulin. Decrease in insulin, more so with the low carbohydrate. And so that we had a fairly similar pattern between diabetics and non-diabetics on that. And the home equation, we see non-diabetics, not so much difference and more of a difference in terms of diabetics. This is the largest trial of lifestyle and has been done in people with diabetes. And the study purpose is to look at weight loss and the effects of weight loss on cardiovascular disease. It's out about the results have been published to about 4 years. And the eventual study will report cardiovascular events. This is only going to be reporting in terms of blood values. But basically, it was designed with a two-arm. It did not look at a low carbohydrate arm. So it looks at low fat, but does not look at low carbohydrate. It was basically a usual diet and alerts being sent to their physicians. And the low-fat diet approach was both low-calorie and low-fat. And they got structured. They got basically a formula diet to start off with, and they were asked to exercise 175 minutes per week. And it has about 5,000 people in the trial. And in terms of medication, in the intensive lifestyle arm, what we're seeing is basically people who were not on meds, fewer going on to meds than in the people who were treated with an alert approach. And in terms of continuation, there is some differences, but you see they're pretty modest. Going on to insulin, you basically see lower levels on people with the intensive lifestyle. And same in terms of continuation. Hypertension medications, we see some significant differences early on, but later on we see that sort of washing out. In terms of continuation, we do see more of a difference with the intensive lifestyle. Lipid-lowering medications early on, but in terms of continuation, once somebody has started on the statins, they basically tend to stay on the statins. So that we see basically in terms of medication use, and the blood values were actually very similar in terms of a decrease. And this is looking at a low-fat diet. Why was it a low-fat diet? Interestingly, the history of that is it started with a diabetes prevention trial in which the investigators made the decision they wanted to lower calories, and it was thought that the literacy level in the population they were going to be studying was low enough that it was going to be easier to use counting grams of fat than counting calories. but it was combined with physical activity. This is an examination of the glycemic index, looking at 14 studies, a meta-analysis, and what you see is, by and large, there's a small difference in terms of glycemic improvement with using foods that have a higher a lower postprandial blood glucose excursion, but you see a very large variability with, but overall, it is an improvement strategy that one would first look at total carbohydrate and then look at glycemic index as a secondary approach. Although glycemic index is calculated usually with subtracting the fiber first, and if you subtract the fiber, then you're going to have a lower carbohydrate content, so that trying to separate this out from fiber can be challenging, because if you're trying to reduce it, you're going to see less of an effect than if you leave the fiber in and look at the glycemic effects. There had been a question posed about protein and in terms of appetite, and I knew that Dr. Feinman was going to talk about it from another perspective, and I looked at some of the potential mechanisms. Certainly it can have an effect in terms of satiety, basically, and we're going to look at some of the hormones in the next slide. Thermogenesis, we know that the cost of energy for metabolizing protein is higher than from carbohydrate or fat, and it looks like it may preserve more lean mass with a higher protein intake. So these are some of the potential advantages of a bit higher protein. However, with people with diabetes, there is concern if they have any impairment of renal function. So anybody who is having elevated creatinine level or spilling protein, generally the recommendation is to restrict protein. And basically, what we see in terms of regulating appetite, it looks like cholecystokinin levels are affected by protein, and that ghrelin levels are affected, and whether any of the other hormones are affected that regulate appetite. So this may be the mechanism by which protein has an effect on appetite. In terms of vegetarian diets, there have been a couple of trials suggesting vegetarian diets have achieved a better glycemic outcome. But I think that in looking at a population base, this is looking at vegans, lacto-vegetarians, people who are fish eaters, people who describe themselves as semi-vegetarians and non-vegetarians. And what's interesting is what we see is basically the physical activity level, the body mass index level is lower in the vegetarians and goes up to the non-vegetarians. Basically, when you start taking out food groups, you basically often have a restriction in calories. A lower carbohydrate diet often is also a lower calorie diet. But what we also see is physical activity tends to be higher, television watching tends to be lower, and sleep tends to be better. So that basically vegetarians have overall better health habits than people who are non-vegetarian, so that it would be hard to sort out the effects. But in the clinical trials that have been done by Neil Bernard and some of his colleagues, their efficacy analysis showed better effects, but their effectiveness analysis did not. So again, these are some of the kinds of challenges in looking at different sources, and I believe this is my last slide. So I think we're ready for discussion.